Uh, Good evening, everybody. It's my pleasure to invite all of you for this adding pieces to puzzle, solving the enigma of endometriosis, module 4. And I am Dr. Pratap Kumar from Department of Reproductive Medicine and Surgery, Kasturba Medical College Manipal. Along with Acumentis, Harmonica, and Dartmouth, we are bringing in the fourth module of this particular endometriosis and its problems. So we have, of course, I am from Manipal, from Karnataka state, and I wouldn't introduce myself anything more. We have had three modules. Module one was challenges in understanding the pathophysiology by myself, chaired by Dr. Rishikesh Pai. Now, module two was deep infiltrating endometriosis, difficulty in diagnosis and management, and that was by Alberto Vasquez Rodriguez from Spain. It was chaired by Nandita Palshetkar from Mumbai. The third was and understanding pain in endometriosis by Dr. Sia Saran Sharma from UK, chaired by Dr. Narendra Malhotra from Agra. And today we are having a very interesting session by Dr. Madhuri Patil from Bangalore. And we have a lovely lady who's going to chair this session, Dr. Jaideep Malhotra. Jaideep is one of those power ladies. I always say that. She has all the power in herself, and her thinking is great. And she has conducted several workshops and conferences all these years in Agra, and I've been witnessing her capabilities for many, many years, and very close to me, their family, and myself. She is at the moment chair of FIGO Committee of Reproductive Endocrinology and Infertility, called REI, managing director of Rainbow IVF in Agra, past member of FIGO working group on several occasions and several committees, member accountability group of PMNCHWHO, past president of FOXY, ISAR, Aspire, and IMS. At present, she is the president of SAFOMS and vice president of Indian Society of Aesthetic and Reproductive Gynecology. I present to you Dr. Jaideep Malhotra.
Thank you, Pratap. Thank you so much. And a very good evening to all of you. It's such a pleasure to be chairing this session, this wonderful, wonderful session, because endometriosis has always been an enigma. And it's not only about the pathophysiology, everything about endometriosis, like we are not very clear. And as an IVF or an ART specialist, it becomes even more difficult when you have to stimulate these patients for ART or even IUI cycles. And I think we have a wonderful, wonderful speaker. I'm sure everyone knows Dr. Madhuri Patil, very, very academic and always updated about all the recent advances. And it's my proud privilege to introduce her to each and every one of you. Madhuri currently is the chairperson of the Aspire SIG of Reproductive Endocrinology. She's also the president-elect and the founder member of the Fertility Preservation Society of India, and the vice president and the founder member of the PCOS Society of India. And she is on the governing council member of ICOG. I have yet to see a more hard-working person and who's so prompt. You send her a message in a minute, the reply will come. You ask her for any help, and she's always there to help you. And I think there are many, many qualities about Madhuri which I really admire, and she's the most inspiring persons I have ever known in our own country as far as academics is concerned. And she is also the associate editor of the Oncofertility Journal, and is also the member of Education and Accreditation Committee of Aspire and Aspire SIG on implantation. So, Madhuri, the stage is all yours. I know you've written many books. You're coordinating many activities. I can go on and on and on, but I want to listen to you now. So, the stage is all yours.
Thank you very much, Jaideep, for that introduction, and Pratap for inviting me. And I think, hope I do justice from the beginning. So today I would be speaking on ovarian stimulation and its difficulty in endometriosis. And we are aware that controlled ovarian stimulation in endometriosis may be affected by the disease itself, by surgery done for endometriosis, especially endometrioma, as well as we know that fertility decreases with age, and if we have a woman with endometriosis and who is more than 37 years, definitely it is going to affect the stimulation. So the different mechanisms for ovarian tissue damage, which is induced by endometriosis, could be inflammatory in nature, where there is increase in the number of immune cells, there is elevated levels of cytokine, chemokines, and reactive oxygen species, and also we know that there could be tissue fibrosis. There could be also mechanical damage, where there could be compression and stretching of the ovarian tissue. There could be hampered blood circulation as well as disturbed neovascularization, and this can then affect the ovarian reserve as well as ovulation. It can also affect the ovarian response to stimulation and the resultant pregnancy rates. Here we can clearly see that the AMH is reduced not only in the presence of stage 3 and 4 endometriosis, but also in the presence of mild to minimal endometriosis, that is stage 1 and 2. And you can see that the AMH levels are much lower as compared to those with tubal factor infertility. And also there is an altered ovarian follicular cohort as compared to those patients who have tubal factor infertility. And in women who have both endometriosis as well as endometrioma, we know that the ovarian reserve is affected. And if you look at the AMH values in these in these studies, and when you compare them with the controls, we can see that the AMH is significantly lower and the p-value is also significant. When we look at the antral follicular count, where we compare the affected ovary and the contralateral ovary, again, we can see that the antral follicular count is significantly lower as compared to the contralateral ovary. And in patients who have endometriomas, we can see that the number of eggs retrieved is significantly less as compared to the control group. This was another recent paper which was published in Fertility Sterility in 2018, and it also concluded that there is a reduction in the AMH values in patients who have endometriomas, and as compared to the those women who have benign cyst, and as compared to healthy ovaries. And this was statistically significant, which we can see in this forest graph, and the p-value was less than 0.0001. This was another paper which was published in Fertility Sterility again in 2008, and it said that there is a lower rate of spontaneous ovulation in unoperated ovaries with an endometrioma. And it also concluded that endometrioma is associated with progressive decline in the ovarian reserve, with progressive reduction in AMH levels, which is faster than the healthy controls. Then coming to the impact of endometrioma surgery on ovarian reserve, a cystectomy wherein always a small amount of normal ovarian tissue and cortex is removed, which has the primordial follicles, results in reduced AMH as well as antral follicular count, and ovarian endometriosa ablation, wherein the cyst wall is cauterized, or when a vaporization with CO2 laser is done, there is both decrease in antral follicular count as well as AMH. So what is the mechanism of decreased ovarian reserve due to surgery? So it has been seen that there is a possible relationship between surgery-mediated damage and an healthy ovarian parenchyma. And here, as we can see, that this is the cyst wall, and then you have the ovarian tissue wherein you have the primordial follicles, and then this is the blood supply, which again can be affected. So basically, when it has been observed that the healthy cortex containing significant number of follicles are stripped with the pseudocapsule, there could also be surgery-related inflammation. There could be vascular compromise due to coagulation. There could be blood vessel injuries, as we can see that they are quite close to the cyst, and adhesiolysis and subsequent injuries of the blood vessels are seen, especially in the presence of adhesions, and it could affect the blood supply to the ovaries. And basically, the technical skill and ability of the surgeon is very, very important. It has been observed by various authors that there is decline in the AMH levels due to surgery, and some of them said that it could be temporary, and a long-term follow-up after 12 months have shown promising partial recovery of the ovarian reserve markers. The serum AMH decrease was more prominent after bilateral endometrioma excision than unilateral excision, and removal of a bilateral endometrioma has a higher risk of premature ovarian failure. So let us then look at the evidence on the effect of endometrioma surgery on the ART outcome. So if you look at this paper, which was published in 2005, they looked at the ovarian recovery after laparoscopic enucleation of the ovarian cyst. And you can see over here, when they compared the intact ovary with the operated ovary at the first post-surgical evaluation, it was only the side of ovulation, which was significantly different, and the operated ovaries did not ovulate as much as the intact ovaries. But when they evaluated the patient the second time, they saw that the mean ovarian volume significantly decreased in the operated ovary as compared to the intact ovary, and this was statistically significant. And also, you can see that there was no ovulation from the operated side, whereas that from the intact ovary was 100%, and this was also statistically significant. This was another paper in 2012, which again looked at the impact of excision of the ovarian endometrioma, and they followed up of the patient at 1 week, 1 month, 2, 3 months, 6 months, and 9 months. Some of the studies have followed only to about 3 months, and you can see that over here that the AMH values have gradually decreased over time after the surgery. This was another paper which was published in Human Reproduction, which looked at the prospective assessment of impact of endometrioma and their removal on the ovarian reserve. And you can see the AMH values, the preoperative, the 1 month, and the 6 months. And you can see that there's not much change in the antral follicular count. But if you look at the AMH values, they have gradually decreased over the 6 months. And when bilateral endometriomas are removed, again, you can see that there's not much change in the antral follicular count, but the AMH values have decreased significantly. These were two other papers wherein the first one looked at the removal of the unilateral endometrioma, and they found that there's decrease both in the AMH concentration as well as the antral follicular count. And this was a second paper which looked at the ovarian reserve markers before and after excision, and was basically at 1 month and 6 months. And you can see that there's definitely decrease in the AMH values, which we saw in the previous publications, but there was no decrease in the antral follicular count. And this was a meta-analysis which was published in 2014. And here we can clearly see that the AMH values significantly were higher before surgery as compared to post-surgery. And this was again statistically significant. And same as that with the antral follicular count. So we know that today the concept has changed, and wherein we really do not operate the endometriomas before ART unless the patient has severe pain, or we cannot access the follicles, because it was seen that even after surgery, there was no effect on the total dose and duration of the stimulation in the presence or absence of endometrioma. Moreover, the number of oocytes retrieved also were not significantly higher, and though when they looked at the overall effect, it was not significant, but in the presence of when the entire study was taken into consideration, you can see over here that in the presence of endometrioma, the number of oocytes retrieved was definitely lesser. And if you look at the number of embryos formed, again, we can see that much less in the presence of endometrioma as compared to the controls. And if you look at, there are several other papers which were included for the meta-analysis. And if you look at the implantation rate, clinical pregnancy rate, and live birth rate, you can see that there is no difference even if the endometrioma has been operated. And this was another paper in Human Reproduction Update in 2015. And they looked at the effect of endometriomas after surgery and before surgery. And what they found that in the presence of endometrioma, it really did not hamper the ART success because there was no effect seen on the live birth rate, on the clinical pregnancy rate, the miscarriage rate. But you can see that the cancellation rates were definitely higher in the presence of endometrioma. But after surgery was done, again, you can see that the live birth rate, clinical pregnancy rate, and miscarriage rate, there was no difference, but probably the cancellation rate definitely improved after surgery, though it did not reach statistical significance. So then what are the parameters which influence the reduced ovarian reserve by surgery? So one is presence of unilateral or bilateral endometriomas, and we know that removal of bilateral endometriomas is more harmful. Pre-surgical ovarian reserve is again important, and if the reserve is low or the woman is of advanced age, the results are have more detrimental impact of the surgery on the ovarian reserve. We also need to look at the characteristics of and the follicular density of of the endometrioma's wall, and whether they are the fibroblastic type, which is usually seen in younger patients, wherein you have high number of follicles, or it is fibrocystic, which is seen in older patients and have small number of primordial follicles. The most important is the capability of the surgeon, how experienced the surgeon is, and how and what ability he has to minimize the removal of healthy tissue. He should also be able to identify the endometriotic infiltration extent and the lesion borders before dissecting the endometrioma, and minimize the coagulation during surgery. And we have to know that repeated surgeries for decreasing the recurrence may decrease the ovarian reserve significantly. And therefore, one has to weigh the benefits and harm of any surgery for endometrioma for promoting fertility. And therefore, a tailored therapy for endometrioma is necessary. And the most important strategy is to operate for a correct indication. And we need to take into consideration the age of the patient, her symptoms, the endometrioma size, the concomitant complicated deep endometriosis, location or difficult transvaginal retrieval. If it is there, then probably we need to operate. If there is rapid growth or suspicious features on ultrasound, that probably it is malignant, and also the potential for rupture during pregnancy. And one must adopt a more conservative approach in patients who are asymptomatic, who are older, and those who have an established low ovarian reserve. The second strategy is to use a meticulous technique wherein we need to identify the right dissection plane. We have to use delicate maneuvers, avoid tearing of the cyst wall as well as the ovarian tissue, and also do a selective hemostasis using the water test to avoid a lot of cauterization, and probably suturing may be a better option. Coming to the third strategy, where we are doing the ablative surgery, so we need to compare the cautery versus laser, and most of the papers have said that lasers result in decreased injury to the normal ovarian tissue. And thereafter, there were several papers which were published, and they said that there was significant improvement in the antral follicular count when laser vaporization was used. These studies also reported that the rate of AMH decline after vaporization is significantly lower than after cystectomy. And this was one study which said that at 5 years follow-up, there were not statistically significant differences in the recurrence rate when ovarian cystectomy was compared with laser vaporization. And according to the most recent ASHRAE guidelines 2021, which endometriomas should be operated. So basically, it is important that the clinicians should be recommended not to routinely perform surgery for ovarian endometrioma prior to ART to improve live birth rate, as the current evidence shows no benefit, and surgery is likely to have a negative impact on the ovarian reserve, which has a low quality evidence. Surgery for endometrioma prior to ART can be considered to improve endometriosis associated pain or accessibility of the follicles, which is a good practice point. And the decision to offer surgical excision of deep endometriosis lesions prior to ART should be guided mainly by the pain symptoms and the patient's preference, as its effectiveness on reproductive outcome is uncertain due to lack of any randomized studies, and this also has a very low quality evidence. Then coming to the ovarian response in the presence of endometrioma, we know that it is associated with lower response as well as higher dose of gonadotropin usage, and poor response was seen in about 27% of the cases. In women with unilateral endometriomas undergoing IVF, ovarian responsiveness to control ovarian stimulation did not markedly differ between the affected and the intact gonads in women carrying small unilateral endometriomas. So basically, it is only the large endometriomas that is going to make a difference. The ovarian responsiveness was significantly associated with the size and the number of endometriomas, and the reduction in the ovarian responsiveness could be observed only in the presence of large cysts, which are more than 5 centimeters, and in those patients who have bilateral disease. Poor response to ovarian stimulation, even if the fertilization rate and high quality embryos are comparable to the unoperated ovary. So we know that basically it is a quantitative and not a qualitative damage post removal of endometriomas. We also know that lower number of oocytes are recovered in women who have endometriomas, and this could be because of technical difficulties during the oocyte retrieval due to ovarian adhesions, or they could be decreased follicular recruitment because of the presence of ovarian endometriosis. And it has also been seen that cytokines specific to endometriosis can affect the ovarian response to the medication given for stimulating more number of follicles. The molecular mechanism which is involved in the poor oocyte quality is basically related to increased oxidative stress, cell cycle dysregulation, inflammation, and impaired angiogenesis, which promotes decrease in the oocyte quality that contributes to infertility in patients who have endometriosis. And this poor quality of oocytes, which is, as I told you, related to the cell cycle dysregulation, abnormal characteristics which are seen, and dysregulated molecular mechanisms, can then result in decreased embryo quality, wherein it has been observed that there is a decrease in the blastocyst hatching. There could be excess of cellular fragmentation, cell death surrounding the blastomeres, altered blastomere division, as well as there could be an early embryo arrest. And this can then result in adverse clinical outcomes, wherein you can have decreased fertilization rates, reduced implantation rates, as well as decreased clinical pregnancy rates. So in this paper, you can see wherein they looked at the response in patients with endometrioma who were previously treated, and you can see that the number of dominant follicles and eggs retrieved from the disease site were significantly lower as compared to the normal site. There was another paper which looked at the number of oocytes retrieved, the embryos obtained, and the pregnancy rates. And you can see that the oocyte retrieved were significantly less as compared to the controls. The embryos obtained were also significantly less. But if you look at the pregnancy rate, you can see that there was no difference between those patients who had endometriomas as compared to the controls. This was another paper in 2007, wherein they analyzed the women with advanced stage endometriosis and previous surgery, and they found that they respond less to the gonadotropin stimulation. And you can see, but basically, they said that there was no difference in the implantation rates. So we can see that the number of oocytes retrieved as well as mature oocytes are significantly less as compared to tubal factor infertility. But if you look at the total number of embryos obtained as well as the cleaved embryos are also significantly less. But if you look at there was no difference in the fertilization rate, cleavage rate, and the number of embryos that are available for transfer, and the mean number of transferred embryos. There was not much difference. Then this was another paper which was published in 2008, And basically, they looked at the IVF outcome in those women who were operated for bilateral endometriomas. And you can see over here that the number of cancel cycles were much higher in patients with endometriomas. They were associated with poor response as well as increased doses of the gonadotrophins. The number of oocytes received was significantly less, but if you look at the pregnancy rate per started cycle was significantly less. But if you look and the implantation rate also was less, whereas some of the papers said that there's no difference in the implantation rate as well as the clinical pregnancy rate. As well as if you look at the delivery rate also, you can see that it was significantly less as compared to the controls. So there's a lot of controversy, as we have seen, where in some papers, though we know that all are agreeing on decreased response as well as decreased number of oocytes retrieved and excessive dosage of gonadotrophins required. But some of the papers say that there's no difference in the fertilization, implantation rate, and clinical pregnancy rates and the live birth rates, whereas there are other papers, as you see over here, which say that there is a definite decrease even in the ERT outcome. This was the most recent paper, which was published in 2018, and it looked at the effect of endometriosis on the live birth rate. And here you can clinically see that there was statistically significant increase in the gonadotrophin dose, decreased number of oocytes retrieved, mature oocytes, but you can see there was not much difference in the number of fertilized oocytes, and the percentage fertilization was much less over here. You can see in the unexplained infertility group as compared to the endometriosis group. And the number of cleavage embryos were again much higher in endometriosis group as compared to the unexplained group. So there's a lot of controversy, and uh, each author and researcher has reported different results. And therefore, we know because endometriomas are associated with decreased ovarian reserve, and the surgery especially can decrease the reserve further. And therefore, choosing the right dose for gonadotrophins is important. But as in any other case, basically the initial dose is determined according to the patient's age, the ovarian reserve, wherein we take into consideration both the annual follicular count as well as the AMH, the BMI of the patient, and also response to prior stimulation regimes if we have the data with us. The initial dose could vary anywhere between 225 to 300 international units, and then the dose is adjusted according to the response of the ovarian follicles, which were followed up via vaginal sonography. And there's no evidence of preference of FSH or HMG, though LH activity can give better response in those with low ovarian reserve. The most controversial is whether we need to use a GnRH agonist or antagonist. Uh, and basically, the initial ESHRE guidelines published in 2000 said that we need to consider GnRH agonist for about 3 to 6 months before IVF ICSI, and this had a grade A evidence. And today, what evidence we have is that long-term GnRH agonist therapy before IVF for improving fertility outcome in women with endometriosis has uncertain benefit. And here, if we look at the various studies now, which I'm going to show you, and this was the first study which was published in 2007 in fertility and sterility. And if you look at endometriosis stage 1 and 2, there's basically no difference seen when you use an antagonist or a GnRH agonist. In those patients with a resected endometrioma, basically antagonist resulted in lesser number of metaphase 2 oocytes, and the fertilization rate as well as the number of embryos available was less, though the clinical pregnancy rate, abortion rate, and the implantation rate was not much different. Whereas in patients who had an active endometrioma, and when they compared antagonist versus agonist, you can see that the E2 level on the day of HCG was much lower with the use of antagonist. The number of dominant follicles was much less. The retrieved oocytes were also significantly lower. The metaphase 2 oocytes were also less, and the number of embryos available were less. But again, we can see that there's no difference in the clinical pregnancy rate miscarriage rate or the implantation rate. And when they did a subgroup analysis, again, you can see between the antagonist and the agonist, we can see that the metaphase 2 oocytes were less in patients with who are given antagonist, and the number of available embryos were also less, whereas all the other parameters were not were almost similar in both the groups. This was another paper which compared the ovulation induction protocols after endometrioma resection. And what they found was that the number of follicles on the day of HCG were much greater with the long agonist protocol. There was no difference in the HCG or duration of stimulation. The number of M2 oocytes were also greater with the agonist protocol, and the number of grade 1 embryos were also more. But if you look at the mean number of embryos transferred, a biochemical pregnancy rate and the ongoing pregnancy rate were almost similar in both the groups. And therefore, they concluded that the long GnRH agonist and the antagonist protocol both present similar IVF outcomes in patients with endometriosis who have undergone laparoscopic endometrioma resection surgery. And the long agonist protocol may lead to a higher number of embryos which can be cryopreserved, providing the possibility of additional embryo transfer without having to go through the process of COL, control ovarian stimulation again, and thus probably have an increased cumulative pregnancy rate. The Cochrane review in 2019 also looked at the prolonged GnRH downregulation before ART and compared it with an antagonist protocol. And contrary to the previous findings, they concluded that it is uncertain if the long-term GnRH agonist therapy has impact on the clinical live birth rate, clinical pregnancy rate, multiple pregnancy rate, miscarriage rate, the mean number of oocytes, and the mean number of embryos retrieved. There's also paucity and very low quality of existing data, particularly for the primary outcomes which were examined. Recently, in 2020, there was another meta-analysis which was published, and it's concluded that the GnRH agonist ultra-long protocol can improve the clinical pregnancy rate of infertile patients in RCT studies, especially in patients with stage 3 and 4 endometriosis. However, the results of the subgroup analysis suggest that the different downregulation protocols provide no significant difference in improving the clinical outcome in patients with endometriosis in the non-RCT studies. So if you look at the fertilization rate and the clinical pregnancy rate, when you compare the agonist with the ultra-long with the long protocol, you can see there's no difference in the fertilization rate, clinical pregnancy rate, though the basal FSH rate with an ultra-long protocol was much lower. If you look at the duration, again, we can see that more gonadotrophins were required when an ultra-long protocol was used, but there was no difference in the dose of gonadotrophin required. The number of oocytes retrieved were also similar in both ultra-long and long protocol. And if you look at the clinical pregnancy rate, again, there was not much difference. But when we analyze the clinical pregnancy rate in patients in the RCTs and non-RCTs, and if you look at stage 1 and 2, again, you can see that there's no difference. In stage 3 and 4, you can see that an ultra-long protocol results in a higher pregnancy rate. And when we look at the non-RCTs, again, we can see that there is no difference in the clinical pregnancy rate. And in both stage 1 and 2, as well as stage 3 and 4, because here again, you can see that the p-value is 0.20. And when we look at the live birth rate in stage 1 and 2 in non-RCTs, again, there's no difference. And when we look at 3 and 4 in the non-RCTs, there is a small difference, but it was not that significant, with the p-value being 0.09. There was another paper in RBM Online in 2020, and it looked at the effect of GnRH agonist before IVF outcome in patients with endometriosis, and this was an RCT. And if you look at the study group and the control group, you can see that the total dose of gonadotrophins in the study group was significantly higher. The stimulation rates, stimulation days, and the estradiol it was much higher, and the estradiol was much lower. The total number of oocytes and the M2 oocytes were almost similar. But the presence of immature oocytes was much greater in the antagonist group. And if you look at the cleavage rate, transfer embryos and vitrified embryos, you can see that there's no difference. And the study therefore concluded that 3 months of pre-treatment with GnRH agonist before IVF cycle does not improve the clinical pregnancy rate, has a higher cancellation rate, requires more stimulation days and a higher dose of gonadotrophins. The E2 levels on the day of HCG are much lower, and more immature oocytes and less number of embryos are retrieved. This was another article in 2020 which looked at the live birth rate of 3 control ovarian stimulation protocols in IVF in patients with endometrioma who have undergone a cystectomy, wherein you can see this is the ultra long protocol, this is the long protocol, and this is the antagonist protocol. And you can see that there's no difference in the fresh embryo transfer cycles, whatever was there. There's no difference in the embryo utilization, the implantation rate, clinical pregnancy rate, the live birth rate, miscarriage rate, the ectopic pregnancy rate, as well as the multiple pregnancy rate. And therefore, probably all the 3 protocols are good. And today we know that an antagonist protocol is much more friendly as compared to the GnRH agonist protocol. And this systemic review published in 2019 looked at the effect of ovarian stimulation on progression of endometriosis and its recurrence. And what they concluded was that IVF does not worsen the endometriosis-related pain symptoms, which has a moderate quality evidence. IVF also does not increase the risk of endometriosis recurrence with the moderate quality evidence. The impact of the IVF on ovarian endometrioma, if present at all, is mild, and this has a low quality evidence. But they said that IUI may increase the risk of endometriosis, and this but has a very low quality evidence, and deep invasive endometriosis might progress with ovarian stimulation. And so they concluded that the available evidence is generally reassuring, especially in patients who are undergoing IVF, and does not justify aggressive clinical approach such as prophylactic surgery before ERT to prevent endometriosis progression or recurrence. Further evidence is required before being able to reach a definitive conclusion, and the possible synergistic effect of stimulation and pregnancy are the 2 areas that need to be explored further. There's a new trial which has now been conducted on use of GnRH antagonists as pre-treatment, and which is called as a pregnant trial. So they have just presented the methodology, and it is going to be a double-blind placebo-controlled trial. So it's going to be a multicentric trial, which is going to be a prospective randomized double-blind placebo-controlled trial, where they're going to randomize 814 patients with endometriosis undergoing fertility treatment to elagolix 200 milligram 2 times per day, which is an antagonist, or to a placebo for 8 weeks prior to undergoing IVF. This is going to use a selective inclusion criteria requiring a documented diagnosis of endometriosis via direct surgical visualization or a standardized sonographical evidence. The participants will not be stratified by endometriosis severity or the treatment history, and both fresh and frozen embryo transfer cycles will be included in this study, which is not powered to detect difference in the effect within these clinical subgroups. So let us see whether this giving antagonist for a long term is going to help in increasing the clinical pregnancy rate as well as the live birth rate. So I will end my talk with the following take-home messages. We know that clinicians have to face the challenge of selection of gonadotropin starting dose, especially in women with endometriosis who could have a low ovarian reserve, and probably previous surgery can also affect the recruitment of the follicles and may be associated with low ovarian reserve. An inadequate starting dose leads to insufficient follicular recruitment, which can result in iatrogenic poor ovarian response. And on the contrary, excessive starting dose may be associated with excessive recruitment, but this is usually not seen in patients with endometriosis unless they have an associated polycystic ovarian syndrome. And therefore, it is advised to assess the ovarian reserve by doing an AMH level as well as antral follicular count prior to deciding the dose. And if the patient is going to undergo surgery for removal of endometrioma, then it is always best to do a pre-surgical AMH value and then follow up with the subsequent values. And if the ovarian reserve is low or in the presence of multiple endometriomas, one has an option of doing fertility preservation, wherein you could do ovarian tissue cryopreservation before removing the ovarian endometrioma. And it has been seen that even if you give a high starting dose, it may increase the progesterone levels on the day of HCG, which can increase the cancellation of fresh transfer cycles and also decrease the pregnancy rate if a fresh cycle is done due to the presence of unsynchronized development of the endometrium and the embryo. The implantation rate, the clinical pregnancy rate, the ongoing pregnancy rate, live birth rate, and cumulative live birth rates after control ovarian stimulation in an GnRH antagonist cycle were not inferior to those with an agonist protocol. And the administration of GnRH agonist prior to ART treatment to improve live birth rate in infertile women with endometriosis is not recommended as the benefit is uncertain, though it has a very low quality evidence. In all endometriosis groups, patients treated with agonist protocol have significantly higher number of M2 sites and available embryos that can be cryopreserved compared to patients treated with antagonist protocol. As surgery may affect the response to COS, one should identify patients that may benefit from ART after surgery. And endometriosis fertility index should be used as it is validated, reproducible, and cost effective to determine as to which patient requires surgery. I thank you all for a patient hearing.
Uh, Jaideep, are you there? Yeah,
Yeah,
yeah.
thank you, Madhuri. That was brilliant. Actually, I was just wondering what questions I'm going to ask you because you almost clarified all the controversies which have been there. But we do have a few questions for you, and I think it's time for us to start the interaction. Um, I'm just wondering, like, a lot of times I have a lot of trainees who come to me, and then, they, when we are demonstrating them how to look at the ovarian reserve, especially in endometriosis cases with endometriomas, counting of the antral follicles uh,
Maybe.
becomes quite a challenge. So, any tips or tricks regarding that you'd like to give us?
I think probably, you need to take more time when you're doing your ultrasound. And at times you have, if you have a 3D facility and wherein you can store your images, you store them. And then later on, you look at all the planes wherein then you can identify the antral follicular count. Because when you're doing a 2D, at times it's very, very difficult. And therefore, you do a 3D and you store all the pictures, and then you can go over it again and probably get the antral follicular
And
count.
I think in the newer machines, the Sono AVC
Yes.
facility is available, which also helps, but it's not always present with everyone in
And
their.
basically, what happens with Sono AVC is if the follicle as well as the endometrium are very close by, it is detected as one. So
Yeah,
that also requires processing. So you also need to save all those images
exactly.
and then process them.
Yeah. And a lot of times, like you have to sit down and mark all the follicles and then, count them. But yes, that facility, if is available, can be
Yes.
utilized. Pratap?
Yeah, I think Madhuri, wonderful lecture as always. Yeah, I always tell Madhuri she is the most brilliant person, and I keep talking to her about whatever doubts I have too. And you spoke about fibroblastic type and fibrocystic type. I think one of the audience wants to ask, what's the difference between fibroblastic and fibrocystic?
Yeah, so fibrocystic, wherein it's present for a long time, and it is usually what happens is there's a lot of fibrosis, and therefore the number of antral follicles are much less as compared to the earlier one, wherein it's in the early stages, wherein that much of fibrosis is not there, and that much of the cortex is not affected, and therefore the total number of antral follicles which are present, but the primordial follicles which are present in the cortex are not reduced as much as in the when there is presence of fibrosis.
So fibrocystic means older patient. That's what you said.
Yeah, there's
Yeah.
more of
Yeah,
fibrosis.
yeah,
I'm
correct.
just wondering here, Madhuri, like if we have antral follicles around this endometrioma, is are there any evidences which are available that the oxidative stress in these follicles is much higher than the others which are away from the
Yes,
endometrioma?
yeah, there are several papers. Actually, I didn't put a lot of details because I thought it was for the general public. So it has been shown that the oxidative stress is much higher in those follicles which are closer to the endometrioma as compared to those which are not closer to them.
Okay.
Yeah,
So,
that's
like,
interesting.
what happens, like, if, I mean, we are screening and scanning them every day. So, we do know in most of the cases that these are the patients where we can avoid aspirating the endometrioma during an ovum pickup. But what happens if accidentally or otherwise on the day of the pickup you have, aspirate coming from the cyst into the follicular fluid?
Yeah. So basically, when you're screening them under the microscope, it's very important that once you get the cumulus complexes, you need to really clean them in the flushing media before you keep them into the incubator in the IVF media. And if you have aspirated, it's best then to rinse the needle, because then you just dip it again in the test tube with the flushing media, and the entire needle should be cleaned, and then you aspirate the next follicle. Suppose at times, if the chocolate material is very thick, sometimes it happens that the needle gets blocked. So at that time, I think I normally use a new needle. But there
I
are
see.
people who flush and use it, but at times the flushing really does not help. So at times it really gets blocked. And many a times what happens is, what I have seen is, I sometimes feel that it's a follicle because it's not translucent. It is totally translucent. It doesn't have echoes. But when you do the aspiration, basically it is also an endometriotic cyst. So what we
Yeah,
tell the patient, probably you've got so many follicles, but then when we aspirate, we get lesser number, and then we need to tell the patient that uh, there were many of them which look like follicles were basically also small endometriotic cysts.
yeah, that's interesting. I wouldn't throw a needle out because it's quite expensive. I would just flush
I'm
No,
it
but
just
so
at
much.
times,
wondering.
I think Madhuri has all rich class people, so
at times, it's very difficult to flush and remove the clot. Many a times
Yeah.
it happens that if it's very thick, it doesn't get removed.
anyway, that's interesting
So
point.
what we normally, I'm just now loud thinking with you that these are practical problems which we can face. Would you recommend aspirating the whole endometrioma before we go ahead and do the rest of the pickup, because you accidentally aspirated and you're there inside? What will you do? Because if I just
I
leave it there,
I mean, if it's very huge and I cannot aspirate the rest of the follicles, I would aspirate it. Otherwise, I would not aspirate, because many a time there's a leak, and then when you aspirate it, there are chances
no,
of
that leak
infection.
has already happened, na? That leak has
Yeah,
already
that
happened. That's the
happened, yes.
problem.
Yes.
Yeah.
So
Yeah,
again, that is controversial. I mean, what we should do, and even the
Yeah.
evidence, if you look in the literature, is controversial. Some people say that you aspirate, some people say that you just leave it, even if you're inadvertently punctured it. So I think
Pratap,
it depends.
what will
yeah,
you
At that
do?
no, so it depends basically if it is too large and the patient also has symptoms and we've got less number. I normally would aspirate it, because I feel next time when I stimulate her, probably I would get more number of
yeah.
them.
It's very difficult to aspirate and flush and aspirate. And there's some
Yeah.
two interesting questions by Dr. Pratyusha from Manipal. They're asking about what is your opinion about natural cycle and fresh embryo transfer? And another question is, how do we assess during surgery to the cortex preservation and not further reduce the reserve? The first question
No, no,
is
I didn't.
natural cycle.
That is a frozen embryo transfer in a natural cycle or something?
Natural
Or
cycle. Yeah, yeah, yeah.
frozen embryo transfer.
Because when you do estrogen, I think the endometriosis become bigger sometimes. So I think the
Yeah.
question by
So basically,
Pratyusha,
if the patient
are
is
we?
ovulating, yeah, if the patient is ovulating, I would do a natural cycle, because I do many of my FETs in a natural cycle, wherein on day 2 I see the patient and I just do the E2 and P4, and because I need to see that the P4 is less, And then I call her on the ninth day, and then I, depending upon the size of the follicle, I call her either on alternate days or daily. Once the follicle is about 14 to 15 millimeters, I call the patient daily, because especially we have to identify the correct time of ovulation. And once the follicle is 16 to 17, I do the LH levels. I determine the LH surge, and then the next day I call her and document the rupture of the follicle, and that is counted as day zero. And then, depending upon that, probably you, if it's a day two, day three, or day five, you can do the embryo transfer. Again, it is controversial whether you should give a luteal phase support or not, because normally a luteal phase support is not required when you're doing a natural cycle. But in a patient of endometriosis, I would give, because many a times we know that because of the presence of endometrioma, there could be some amount of luteal phase deficiency. So, in a patient of endometriosis, I do give luteal phase support in a natural cycle. Other patients, I really don't give many times. And I can say 50% I give, 50% I don't give. And I normally don't do a modified natural cycle wherein I don't give a HCG trigger, because I monitor my cycles regular.
Yeah, I think you're
How do
very
you decide?
hardworking because
Yeah,
sorry,
I
go
was
ahead.
just thinking, how do you decide which ones you will give the support and which ones you won't?
So basically, I do the progesterone level one day before the transfer. And if I find the, if the progesterone level is more than 15, I don't give. If it is less than 15, I do give.
Sorry, what you don't give? What
If
you
it is
not
more
give?
progesterone
Oh, okay, right, right.
support.
Interestingly, there's one question from UK from Dr. Sia Sharan Sharma, who was our previous speaker. His question is, it's difficult to aspirate with OPU needle, basically, an endometriotic cyst. So eventually, probably you rupture the cyst. So how do you manage this? You're talking about aspirating the whole thing. So Sia
I
Sharan Sharma
think,
from UK asked this question.
I think it's quite easy. I mean, doing it with the OPU needle. At least I have not found difficulty till now, when, if at all, I've aspirated.
Okay, there's another interesting question from Pratyusha again from Manipal. How do we assess during surgery to preserve the cortex and not further reduce the risk of the aspiration? How do you know exactly remove
Yeah.
the cortex or not?
So once, basically, when you put in the laparoscope, you look at how big the cysts are, and if the patient especially has multiple cysts and her AMH values are borderline, then it is better to look at the normal tissue, and you take the cortical tissue and you process it and you freeze it, because I mean, that is much better, because the surgery is also going to result in fibrosis. So this fibrosis is going to further decrease the uh, ovarian reserve. There are other people who don't do ovarian cortical tissue preservation. What they do is probably they stimulate the patient, they aspirate the oocytes. If she's unmarried, they freeze the oocytes. If she's married, they can freeze the embryos. After that, they do the surgery, and then once surgery is done, and many a times people do give a ultra long protocol, but we've seen that it really does not help, and then they do a frozen embryo.
Yeah, interesting. Jaideep, I think like what you asked about previously, to continue the same thing, about these difficult of antral follicular count, etc. Another interesting question from the audience is, are there more of immature oocytes after ovarian stimulation in endometriosis because you're not able to count exactly antral follicle and then you're not sure about the dose? And you did mention about the dose, Madhuri. You start higher dose. Young patient, 20 years, with not sure about antral follicular count, AMH is just about 1.5. So
I
what's the dose
basically,
start?
I basically start with 225.
Hmm.
And if I find that the E2 level on day 4 of my stimulation is very low, and I find that dominance has not been achieved, I might probably give 300. But I normally don't give more than 300. There must be a very handful of patients wherein the maximum dose I have used is 450 IU.
Oh, okay. Jaideep,
Yeah.
anything you
Uh,
want to ask?
yeah, there are actually lots to ask, Madhuri. I'm
Yeah.
just wondering, because there's so many queries in everyone's mind. Now, at one point of time, when we quote the evidence, we say that the AMH recovery takes a while,
Yeah.
and
Yeah.
you should be measuring after, let's say, 6 months or so, because it takes time to recover.
No, I actually, Jaideep, even I was wondering, when I, read over all these papers. So here, what they have shown that there's only decrease in the AMH, whereas if you look at the antral follicular count, it's almost same. So I was really wondering in the studies, but what in my experience, post surgery, if you look at it, even the antral follicles many a times decrease, at least in my experience. So
Yeah.
I'm not sure
So
about your.
what I was trying to ask you is, on the other hand, the evidence also says that there's no point in suppressing the ovaries, before stimulating them. Now, how do we really go about? Because we also understand that many a times you will have a recurrence of the disease within a month, within 2 months, 3 months. So you can't just leave those patients alone after surgery. So what do you do?
So I think it depends upon how good you've done the surgery. So if you've not removed the cyst wall properly, or you've left certain, because if there are smaller endometriomas which are there, which cannot be identified when you're doing a laparoscopic surgery, I think when they are left, it is those endometriomas which grow. And if you have not properly, removed the cyst wall, and when you're removing the cyst wall, this is the time when the normal cortical tissue also gets removed, and that reduces the ovarian reserve. So I think meticulously finding out the interface between the endometrioma and the normal ovary, I think is very, very important.
Yeah, thank you so much, Madhuri. There's one interesting question about post-operative suppression. You do an operation and surgery, remove it, then there's for IVF. Do you think that we should suppress for about 3 months with analogs and then do the IVF?
Yeah.
So
So
what do you think?
initially, I think must be about 4 to 5 years back. I myself is to suppress, but I now for the last I think 3 or 4 years, I normally just use an antagonist protocol, and I don't really suppress. And what I found was there was not much difference.
But how
Nowadays,
long
I'm
do
not.
you wait? How long do you wait after the surgery to stimulate them?
Basically, I do the next month or the month after that. Not I don't wait for a longer time. If I'm going to wait for a long, then you can always use the long, ultra long protocol. But I don't think initially I used to use the ultra long protocol, but I think for the last 4 5 years, I don't think I'm using it that much.
Because, yeah, that's interesting because in your talk you did
I still
mention
use
about
it. Pratap,
yeah,
I'm just wanting to say that, what we have to understand is that there's no difference between the agonist and the antagonist protocol
Yes.
as
yeah,
as such. An antagonist protocol is maybe, more patient friendly or less time consuming. But wherever you have decided to wait, I feel ultra long protocol, there's no harm in
Yes,
doing it, because the cohort and the number of follicles, the uniform ones, they're all very good. I mean, I still
actually,
use it in
no,
quite a few cases because it's very convenient to do.
I basically use it in more in patients who have a low ovarian reserve, because what happens in these patients is because their intermenstrual FSH is very
Yeah.
high because of the low ovarian reserve. You don't get a uniform cohort of follicles, and therefore, though you have 5 or 6 follicles, you might just have two which are dominant. So I think in a poor responder, I still use a
Yeah.
long agonist protocol, especially if she's got a previous history where she's got less number of oocytes, or she's not got a uniform cohort, or if she's taking treatment with me wherein I've done 1 or 2 cycles of IUI and I find that the cohort is not uniform, I do still use a long protocol, especially in those patients who have a poor ovarian reserve.
and that's interesting. Endocrinology has become endocrinology. So inside a cell, what happens? So do you think this letrozole has been or maybe used for along with your stimulation protocol?
For what stimulation protocol?
Ovarian stimulation with letrozole and
Yes,
along maybe alone
basically,
or with gonadotropin.
it has more than one mechanism of action apart from his aromatase inhibitor, where it reduces the estrogen levels and there's a negative feedback. It also increases the IGF-1 levels, and it also increases the sensitivity of the granulosa cells to FSH. So these are the two more important factors when you're using letrozole for ovulation induction. And because today we are using a lot of antagonist protocol, we can combine the oral ovulations with the gonadotropins. But if you're using a agonist protocol, you cannot combine a oral ovulation with and with a gonadotropin.
Yeah. And
You
you
know,
also
recently,
mentioned about, sorry, Jaideep, there's one last question
sorry.
from me before
No,
the leave.
recently I attended one of the very high profile endoscopy workshops on endometriosis. And I actually, what there was a presentation there where butterfly resection of the peritoneum, especially
Wow.
with deep infiltrating endometriosis, and some excellent results were being projected after the resection, even with natural pregnancies happening and also with ART. Now, and it was all about the oxidative stress which was happening because of widespread endometriosis. I am not propagating surgery, but I mean, we had a huge debate and a huge argument on that, but it was something which I came back and I read also. There are plenty of studies which are happening. This is only a comment for people, especially where you may not get good quality oocytes, or a pregnancy rate which is not happening after the first bad IVF outcome. They are considering it, and there are studies from India. In fact, this study from India, Lancet has sent a team, because the number of cases which they have done is so much that they refuse to believe it.
No,
So it's there is a lot of insights which may be coming up, but right from now, at least we know that evidence suggests that surgery does not really improve the outcome.
Yeah, I had a patient, you won't believe it, who came to me who had undergone three endoscopic surgeries before she came to me for endometriomas. Then she came, and then she had also undergone, I think, 3 fresh cycles, and she had undergone 2 fresh cycles. She had a hydrosalping. So I said that probably that hydrosalping, which they have not clipped, is causing. But she was not ready for any surgery. I said, fine, not an issue. So I did a one fresh cycle, and she again had endometriomas, large ones. But I did a fresh cycle for her. She did not conceive. She had some oocytes, so I did a frozen cycle. But then she had fluid in the endometrial cavity, and she said. Then again, I convinced her that let's at least just disconnect, because it was a totally plastered uh, pelvis. And she said, no, let me try one more cycle. So we did another fresh cycle, and she didn't conceive. So then she was ready. And because I think her endometriomas were almost, she had about 3 on the right side, and she had about 4 on the left side. So what I did was, when I put in the scope, I don't think I could have even touched the ovaries. So I just, dissected a bit, and I just disconnected the tubes. But then I did a transvaginal aspiration of those endometriomas, and I gave her a depot preparation for 3 months. And after that, I did a IVF. And during the fresh cycle, again, she had some amount of probably endometritis or something. She had some free fluid, so we didn't do. But then we did a frozen embryo transfer, and she conceived. She's got twins. Now her children are almost 8 years old. So, and she was a very positive patient. So I think the positivity from the patient also is very important, apart from whatever treatment we are
Yeah.
giving our patients.
interesting. That's nice. Jaideep, you want to say the last few words and then I would conclude. Or if any of the
Yeah.
questions, I think there are some more questions. Jaideep, if you want to ask any more questions, you can.
Actually, there are quite a few questions, but I think Madhuri has answered. But one
Yes.
of them is asking, like, would you like to do a flare stimulation protocol for these patients, or do you do?
No. Because what happens with the when you're doing a flare stimulation, wherein you give only for 3 days, you give the GnRH agonist, and then you wait, and then you start the antagonist. Many a times there is an increase in the LH, as well as which results in a premature increase in the progesterone level. So preferably for an IVF cycle, I don't do that.
And is there anything special you would like to say about the trigger? Is the dose of the trigger same, or do we do a little
I,
lower or
I
a higher?
normally No, I normally use the same trigger for everybody, unless
Okay.
I find that there are a lot of immature uh, oocytes which I've got in the previous cycle. Then probably I would use a double trigger, wherein I would give both a agonist as well as HCG.
Thank you
Okay.
very much, Jaideep and Madhuri, for excellent discussions. And I always feel I've got lovely two women who are super brains, Jaideep Malhotra and Madhuri. And what a pleasure to listen to all of you. And today we have a huge number have registered today. Exact number I will know tomorrow, but we have surpassed 900 registrations here.
Awesome.
And yeah, awesome. I think a lot of postgraduates have joined in. We have started MCH courses in Manipal for reproductive medicine surgery. There are about 7 centers, and all the centers have logged in today. And along with the specialists from all over, and even UK, dear friends, yeah, Sharma is also there. And I think Madhuri, I always tell everybody if I have to refer to anybody, I'll refer to Madhuri for my, if I don't know something, I'll call up Madhuri. And she is always ready, super brains. And Jaideep, you're another, lovely person, always willing to help everybody. And congratulations for yesterday's 20, 26 years, 25, 26
Yeah,
years.
25 years. Yeah,
25
thank
years
you.
your IVF celebrations, and your baby is now
Yeah,
25 years. First one. That's great. And I think I must thank all of you for the lovely participation. The delegates who have come in large numbers today. And of course, Acumentis Harmonica and Dot Mode for the wonderful session. Thank you so
thank
much. And
you.